If you go on the internet and look at the age range typically associated with infancy and toddlerhood, you might be surprised, even if you're looking at nice quality sources as compared to so-and-so who's just talking about it, that they won't match your textbook. Most sources on the internet will say infancy is the first year of life and toddlerhood the second. Now compare that to your textbook. It says the period of infancy and toddlerhood is from birth to age 2. So I would like you to just know both and try to accept this contradiction. And a hallmark, if you're interested in Asian thinking, is to generalize, is the acceptance of contradiction. So there you go. Probably not surprisingly, brain development is an interaction between genes and environment. Or what other way did we learn to say that? Think for a moment, I'm sure it will come to you. I assume that you're saying to yourself very loudly, nature versus nurture. Nature, of course, referring to the genetic component, and nurture, the learning and environment component. As you note in the slide here, environments are a continuum from being basically the best imaginably possible to being the least favorable imaginably possible. Perhaps if you want to think the least imaginably possible quality environment, maybe think of the case study with Jeannie, raised in the attic. Most children fall somewhere between the best and the worst, hopefully leaning those strongly towards the best. Now, from an earlier chapter, you remember the term for a study that looks at the interaction between genes and environment. Think for a moment and see if you can come up with that term, which was definitely much harder than the nature and nurture term. So hopefully you're thinking epigenetics. Now, it might be obvious how the person's genes can impact them. They're like, let's say their love of science and nature and a fascination with living things, maybe insects and frogs. Clearly that could be partially genetics. But how would the child impact the environment back the other way? Well, perhaps in terms of creating a little mini ecosystem in their backyard, getting neighborhood kids to help them catch frogs, maybe doing a mini class, or maybe starting a club in high school or college, looking at some environment perhaps related to global warming, global climate change. So clearly it can be two-way directional, and that would be the focus of epigenetics. So if infants and toddlers kept their body proportions, they look more like aliens than people. If you look at the 1-year-old, their head is approximately 1/3 of their body length. Imagine your current body. Look at it right now if you would, because I am doing it. Imagine if your head was 1/3 your body length. It would be huge. Natural births would not be possible. So at that age, the head is 25% of the body to 33%, depending what age you're looking. By 3 years, 18%. And by adulthood, a mere 6%. Now, this pattern of the head being more developed than the extremities refers to, is referred to in the two terms below, the head to tail, literally cephalocaudal, and the pattern in which the chest area is more further advanced than other areas of the body that are more distant. That'd be the proximal distal. You might see an interesting reverse at proximal distal at puberty, with particularly young men of that age with huge hands and feet in proportion to their body. So that would be a reversal of the typical proximal distal that we see, say, as a fetus. Let's consider the amazing brain of the newborn. It triples in the first 2 years. Imagine your brain 3 times its size. It is amazing. By age 2, the brain is 75% of its adult weight and size. Why? It's not due to the main cells, the neurons division. It's due to the support cells. Do you remember them from intro? You probably learned about them. They have many functions, including they are the makers of myelin. Do any possibilities come to mind? That would be the glial cells, G-L-I-A-L, in case you didn't cover it in intro. So in the last slide, we learned that myelin is produced by the glial cells. The process is really well underway and beginning at birth, and is going to rapidly increase through the first 2 years of age, and that's why we see that really large growth in the brain size. It'll slow dramatically after that. It's largely finished in the 20s, but there'll be a little bit of a completion, the icing on the cake, up until about age 30, but by and large, the bulk of it is done in the early 20s. By the early 20s. Now, malnutrition affects both the general body and brain long term. If you look worldwide, 1 in 5, in other words, 20% of the world's children are affected by malnutrition. If you look within America, 1 in 5, in other words, 20% of American children have food insecurity, meaning where there is not necessarily always enough food in the house, and there might not be a sureness that there'll be enough food to get through the weekend, the week. So food insecurity is sadly very common in a country that's wealthy. Now, if you're facing food insecurity, do remember that with your college ID, you can sign up for 3 visits to our food pantry on the campus a month, only 1 per week. And I'm told that each visit, depending on what you pick, has no less than $150 worth of grocery in it. So by all means, if you need our food pantry, absolutely use it. And there's frequently baked goods in the hallway, so if you should rush to school and you didn't have time to eat or just didn't have the money, also check to see if there's anything out there. So you'll do your best, same as children, if you have enough nutrition to fuel your body and your brain. Many, if not most, of my students are familiar with SIDS, sudden infant death syndrome, but relatively few are familiar with the term SUID. That term was introduced by the CDC, Center of Disease Control, in the early 2000s and has been slowly becoming more and more utilized. SUID stands for sudden unexpected infant death, and SIDS is subsumed in it. SIDS is a category of SUID. Let's consider risk factors for each. To further clarify before we go on, in the non-SIDS form of SUID, there is a known cause. It might be particularly co-sleeping with mom or another parent. It might be a toy that had been placed, or another object that had been placed in the crib, or had accidentally fallen in the crib. So it is identifiable. Versus with SIDS, we don't know the cause, and no degree of autopsy or examination will indicate the specific cause. Now, we do know risk factors to increase the risk, things to be avoided, in other words, such as maternal drug use, prematurity, or things known to increase it, such as anything from lack of prenatal care to, again, drug use, poor nutrition, stress, low birth weight, another risk factor. But let's focus now on the known causes of SUID. So again, co-sleeping is a major risk, as well as accidental or intentional objects being in the crib that could smother the child. I've chosen combined In terms of the non-known causes, SIDS with unknown cause. I do that to be consistent with my intro psych. The difference is in SIDS, they've done an extensive investigation versus unknown cause, there was no investigation. But to me, they're similar in that in the end, there is no known cause. So again, we're going to do this two-tier system, either known cause or SIDS, which is the unknown cause. I hope this makes sense to you and makes the life simpler, not harder. One last detail, as you probably know already, a big risk factor for SIDS is the position that the baby is lying in, placed in the crib. Your text uses the term supine, or I would prefer dorsal or just plain on the back. So on the back is a safer position, on the stomach, ventral, a less safe position. Before COVID, parents opting out of immunizations was pretty uncommon in this country. In New York State, in order to go to daycare, pre-K, and school attendance, certain vaccines are outright required. Diphtheria, tetanus, and pertussis, usually DTaP or Tdap, hepatitis B, the MMR, polio, varicella. If you consider a few of those, varicella, no, chickenpox, people of my age all had chickenpox, and it can be uncomfortable as a child, usually not life-threatening. The problem, though, is it sets you up for later on in life to get shingles. And I don't know if you know anybody with shingles, but shingles are extremely painful. So painful that opiates don't really even take the edge off. It can cause permanent scarring, permanent nerve pain, and it's mostly associated with people maybe 50 or older. But I knew a person in his 20s that got shingles. You might say, well, I'll just get the 2 shots. Well, the 2 shots will make the shingles episode less severe, but you can still absolutely positively get the shingles. Now, next I'm going to pause this and go to the next icon. Let's say that your parents opted out of the MMR and homeschooled you, and you get measles, mumps, or rubella as an adult. This could easily leave you sterile. Also, if a person carrying a baby gets exposed, this could be passed to the baby, causing such severe deficits as permanent blindness, intellectual disability, or death. Now, in terms of polio, I'm sure anybody listening to this is too young to remember whole wards of hospitals with children and adults, for that matter, on ventilators because they could not breathe on their own, and a whole generation of people that were either using canes or braces or wheelchairs because they got polio, and it was not preventable at that point. I can remember growing up when meeting a child, actually she was more like probably teens, and my mother was very angry that this person had polio because her mother could have prevented it with just a simple vaccination. The chart on the left shows you by state which are the most and the least vaccinated states, and we're pretty high in terms of vaccination, which is just good to know. So before you opt out, definitely consider it. And I will just mention opting out of COVID. Right now, the last statistic I saw for the country is only 11% of people are getting vaccinated. Well, that surprises me because I thought that just everybody lost somebody in COVID. I certainly did. And these people had no choice. There was no COVID vaccine. The COVID vaccine maybe will not keep you from getting COVID, but it will keep you out of the hospital, and it will keep you off of being on a respirator in the hospital. So maybe think before twice and make sure you're definitely clear on your reasons if you do opt out of the COVID vaccine. But enough said. So not surprisingly, nutrition affects brain development, and environment also affects brain development, as does genetics, and there's an interplay. And we already had this particular question already, so it should be a slam dunk. So what field recognizes the interaction between genetics and environment? Since it was discussed earlier, and we've only done 11 chapter slides so far, that one I will not answer, but hopefully it's a slam dunk. It's probably quite obvious to you that nutrition affects brain development, and disease or lack of it obviously also affects brain development, but also early relationships. So for example, if you consider the US prior to, say, early 1900s, late 1800s, when there were orphanages, it was not uncommon, this is also true of much of the poorer world, it was not uncommon that for a baby in an orphanage to get enough food but not thrive because the brain needs emotional stimulation. The lack of thriving could actually constitute a condition called failure to thrive. The child would not put on necessary weight, would not grow, and in the severe absence of emotional stimulation, babies can actually die. So not from lack of food, but for lack of human interaction and lack of touch. There's also a lot of research suggesting with preemies that are touched more, that are gently massaged in NICUs, neonatal intensive care units, they'll actually get out of the NICU days earlier, saving them time having their little bodies pierced with little needles, and also saving the hospital and the parents tens of thousands of dollars. So humans are a social species at every age, and for normal brain development, we need stimulation. We said that age 2, the brain is 75% of an adult brain, which is still amazing. But what accounts for that other 25%, given that almost all neurons that we'll ever need and have are present at birth? Well, that would be the addition of the certain cell we mentioned before. Can you remember that cell? If you're thinking glial cells, excellent. So indeed, the difference would be the addition of glial cells. In fact, the neurons will actually be eliminated. So a young child at 2, 3, 4, 5, 6 will actually have more neurons than an adult. How are they lost? Well, two different routes. One is programmed cell death. So if a neuron is not being connected to other neurons, it's just going to be lost. It's going to die. And if it's seldom fired, the synapses, the connections, the spaces, the synapses will be lost. So the neuron itself, primarily through the programmed cell death from lack of use, and the synapses that aren't useful, lost through synaptic pruning. Let's consider reflexes. This is a partial list. You should know that reflexes, some we're born with and they stay with us our entire life, such as maybe sneezing if something peppery gets in our face, or if somebody taps our kneecap, of course our knee will jerk. But this list below is focusing on reflexes specific to childhood. Instead of defining each, I picked out a nice, very, very short clip so you could learn about it and identify the basic components. Some of them have survival value, some do not. They're just related to temporary brain wiring. As I mentioned, some may reappear with central nervous system or peripheral nerve brain damage. Also, when you're viewing them, look at the picture on the right and try to decide which reflex is being shown. So the child will grip anything very fiercely put in their hand. It's a reflex. The grip is so strong that they could actually support themselves if lifted off the surface. So the picture is indeed showing the palmar reflex. Your text correctly indicates it's important for parents to monitor basic physical growth and make sure the child is within the typical region of the bell curve, within where they should be. But it's equally important to monitor milestones. And how does a parent do this? Well, perhaps one of the best ways is to go to the CDC website. The link I've attached is for the CD website, and it can be broken down by months. It can also be broken down by, if you want to look at linguistic versus other aspects of development, and it also has language options. And you might need to just, for one of the particular lecture questions, go to this and answer a question based onto this website. So just be prepared, you'll want to do that. Milestones are related to maturation of the brain, not learning. So the baby is not learning to hold up their head or stand up. We might say the child is learning to walk, but really it's maturational. Same thing with linguistic milestones that we'll look at later. The child's not learning to coo or learning to babble. Again, it's a milestone related to the development of the brain. So let's consider just a few of the very biggest motor milestones. Typically holds head up around 2 months, sitting alone close to 7 months, standing alone very quickly after that, 8 months, toddling a year-ish, more variability here, but a year-ish, walking alone at about 18 months. Initially, the walking might include things like walls or furniture. Let's consider sensory ability of the newborn. Starting with touch, very well developed, as we saw in earlier slides, necessary for physical growth and psychological well-being as well. Extreme lack of it can result in failure to thrive or even death. Smell, very well developed. Basically, as soon as we can get the baby to testing, within days even, the baby can tell mom from other mothers and prefers mom. Smell and taste are often called the chemical senses, often related because of this, or they are frankly related because of this. Taste is well developed. Babies love sweet, as adults do. They do not like milk that's been tainted, such as with tobacco or alcohol, if mom's a smoker or a drinker. Or they also don't like cabbage as well, if mom's been eating cabbage. Hearing is well developed. They like the human voice above other sounds, and they quickly learn and know and prefer mom's voice. Vision is the least developed, and we'll consider vision and visual milestones on the next couple slides. I like this slide because it clearly shows the progression of vision. So before 3 months, vision is quite poor. At 3 months, it's really not bad. Color is almost there, and by 6 months, very nice. Now, if you're thinking about what color to decorate a nursery in, for at least the first, 3 or 4 months, a color scheme with a lot of black and white would be actually preferred, according to test, for the newborn and young infant. They're better able to see the color contrast, and actually can be nice for adults if you put a little bit of color here and there, but black and white is a great choice for decorating the nursery of the infant. Newborns really can't see color, they see more of contrast, so black and white is actually more interesting to them. But by 2 or 3 months of age, they seem to have near adult-like color abilities. In the next slide, I'm going to review one method of learning which allows us to make this conclusion, since they're not really talking much at this stage. Before I move on, I should probably add that their visual range is about 18 inches, not too close and not further than that. So very limited, but perfectly suited to look at the parent's face or the caretaker's face while the baby's being held. How perfect. So let's consider just a couple visual milestones. Focusing, that's around 2 months. The best distance is around 18 inches, a foot and a half, which should be roughly mom or dad or the caretaker's face when they're holding the baby, so that's perfect. Color vision, as we saw in the previous slide, not really much before 2 months. Depth perception, 5 months. How do we study it? The apparatus on the right called the visual clip. Now I just actually did this entire slide narration describing it, but I decided not to. I want you to go into that little short clip starting at 54 seconds and see how this visual clip experiment and test works. So go ahead and actually do it now if you will. Very quickly, our new human being prefers faces over non-faces. You can see the adaptiveness in terms of learning language because you're watching lips, also forming emotional bonds and socio-emotional learning. They also prefer new things over familiar things. You can see how that would be advantageous if you've got so much to learn about. They prefer pattern to non-pattern. Now, if we were to lose the visual idea and move on to auditory hearing, what would be the analogous thing of preferring the human face? So if you follow me, if it's auditory, oral as in O-R-A-L, it would be the human voice, and indeed, babies quickly have a preference of the human voice over other sounds. And if we move beyond oral as an O-R-A-L to olfactory, in other words, smell, newborns, within the immediate time that you can get your hands on them for testing, in a matter of days, are soothed by mom's particular scent over other scents, including other women. So very quickly they're attuned to mom's scent, voices, and the human face. And we can see the advantage of all those. So let's consider some pros and cons on the topic of circumcision this time. Less bladder infections. Bladder infections are much less common in men, but when they occur, they tend to be in either uncircumcised men or much older men. Less risk of penile cancer. Again, a very rare cancer. I did know a friend of a friend that had it, and that's all I know about that person. Less risk of contracting HIV or STI after exposure. Less upkeep. If a child or adult has no foreskin, it needs to be cleaned underneath versus no foreskin. Not necessary. It's expected in some religions, including Judaism and Islam. Sometimes adults do need to be circumcised, and we'll assume that it's more traumatic to have it as an adult than as a baby. You might say, why? Well, sometimes there's a condition where the foreskin fit is poor. It causes too much pressure and discomfort on the head of the penis, and the individual has to be circumcised. I've never had a male share that, but I've had a couple Army wives share that, and it was very painful for their husbands. Cons, well, it is painful. That being said, and I'll cover that in a moment, there should be proper pain control given to the child before the surgery occurs. I can't imagine doing it in an adult without proper pain control, so I wouldn't want to have a baby exposed to such a procedure either. It's a natural part of the body. Presumably it's got a reason to be there. It results in lower penile sensitivity as adult. Cost or not, anyway, cost or full cost may not be covered by your insurance, and it takes away the child's choice. Old skill is for pain control. Put a little sugar on the pacifier. It'd be like having a sip of non-diet soda before you have your tooth drilled. Barbaric. If they'd use a cream, it's called EMLA, but if the cream is used, it needs to be applied 60 to 90 minutes beforehand, so 10 minutes ain't going to cut it. Probably the best by far is a dorsal penile nerve block, where lidocaine is injected. That way it will not be felt. That was the only way I would consider would be reasonable to do. And by the way, complications are very rare. About 0.5% have complication, usually minor, such as an infection on the incision. If I should ask on a test for you to list the pros and cons of circumcision, I definitely would not accept that one is better appearing than the other. Beauty is in the eye of the beholder, and I don't have any desire to make anybody feel bad about if they're circumcised or uncircumcised. So we'll leave it at that. We should mention that one parting detail, which is almost escaping my mind, probably the biggest determining factor when parents decide whether or not to do it is, well, what does dad look like? And we should say that about 70% of babies are circumcised, rounding up a tiny, tiny bit, so the child will not feel out of place in a locker room, no matter what decision is made by the parents. So we just discussed the choice of breast versus bottle, which is not always a choice even, but another choice that may or may not be available would be to circumcise or not to circumcise the male baby. Take a moment and, if you could, humor your teacher again, jot down as many pro-circumcision arguments as you can, and then as many con-circumcision arguments as you can. I did include a picture of a penis in the natural state and the circumcised state on the bottom, should you not be familiar with the looks of each. Let's see what the American Academy of Pediatrics has to say about circumcision. Quoting here, existing scientific evidence demonstrates potential medical benefits of newborn male circumcision. However, these data are not sufficient to recommend routine neonatal circumcision in circumstances in which there are potential benefits and risks. Yet the procedure is not essential to the child's current well-being. Parents should determine what is best interest of their child. To make an informed choice, parents should be given accurate and unbiased information and be provided the opportunity to discuss this decision. If a decision for circumcision is made, procedural anesthesia should be provided. Let's consider co-sleeping, the child sleeping in the same bed as the parent. In many cultures, this is a norm, but in many cultures, people do live in very small dwellings that might be the size of your living room, in which there might be only a couple beds, so the child will have to sleep in somebody's bed. It's a norm in over 90% of the world. It does offer convenience, but it also greatly increases the risk of smothering. The child sleeping in the same bedroom actually decreases the rate of SIDS and is no more associated with increased in smothering. So a crib in the same room, a wonderful idea. Co-sleeping, not. And just as a caution on a related topic, never place a child on a waterbed. If they turn over, their face will be encompassed by the waterbed. They'll just fit right in there and they will smother. So please bear that in mind. Before we leave this module, let's consider newborn arousal states. Let's start with the state they spend the most time in, sleep. Now perhaps you remember from intro psych how much adults sleep. To make it easier rounding-wise, if you sleep 8 hours a day, that's 1/3 of the day. Infants, well, how long do they sleep? To generalize across infancy, twice that, so 2/3 of the day. Now, that would make life very easy for mom and dad, except for the little detail that it's going to take them a while to be able to sleep even 6 hours at a pop for many babies. Now, sleep is not all the same. You probably covered intropsych stages of sleep. Probably you remember REM sleep. And what did that stand for? Hopefully you're thinking REM stands for rapid eye movement. So they spend much more time of their sleep in REM sleep, in other words, rapid eye movement sleep. So basically this has stimulated the brain, so even though they're asleep, their brain is being stimulated by dreams. Now, probably not dreams of playgrounds in Hawaii, but still their dreams will be stimulating their brain. The other half of the time would be in the non-REM stages, in other words, stages 1, 2, 3, and 4. Other states, drowsiness, you might relate to that perhaps even this very moment. Also, waking activity, in other words, moving around, and crying. It's considered to be the same state, so activity and crying. And then the best stage for learning, quiet and alert, looking, listening, tasting, feeling, maybe a combination. So again, the basic arousal states of the newborn, and overwhelmingly it would be REM sleep for a while.